Good evening, everyone. Now, as you all know that this week we are discussing about GI cancers. We are going to learn about cholangio and hepatocellular carcinoma today. And thankfully, Professor Reena Engineer, who has been radiation oncologist and a professor in the Department of Radiation Oncology at Tata Memorial Hospital, Mumbai. Ma'am is very passionate about gastrointestinal radiation oncology and has developed many protocols in the department as well as done a commendable job in this field. Madam has been very graceful to take 2 classes consecutively. Last time she taught us about gallbladder and pancreas. Now today she is going to teach us about cholangiocarcinoma and hepatocellular carcinoma. Thank you so much, ma'am, for joining us, and we'll request you to take over the session and start.
Yeah. So at the outset, like I would be first covering the hepatocellular carcinoma in the radical setting, and then the liver metastatic setting, and then I will be covering cholangiocarcinoma. And where management of hepatocellular carcinoma is concerned, that majority of the patients, they present with unresectable disease, and resectable is only less than 15%, and out of that, very few undergo radical hepatic resection and then or liver transplant. But majority of the patients, what we see in our daily clinics, are unresectable. They are large. If they are small, they undergo RFA, radiofrequency ablation. Hello?
Yes, ma'am. We are hearing, ma'am.
Everybody has to be muted. Yeah. So, and if they are larger tumor, then they undergo TACE. This is transarterial chemoembolization, which is the standard of care, considered the standard of care. And if not, radiotherapy is fast becoming an option in these last 2 decades. And the role of TARE, that is transarterial radioembolization, has gone down, and the role of radiotherapy is coming. So it is very important for radiation oncologists to know where indications, contraindications, and where do we stand today. So traditionally, radiotherapy was not advocated for liver tumors because of the risk of RILD. This is radiation-induced liver disease. But now with these new very modern techniques and breath hold techniques and SBRT, now there's a renewed interest in the role of radiation. And contrary to the earlier belief that, again, hepatocellular carcinoma is radio resistant, it is not. It is extremely radiosensitive, and people are now realizing the benefits of it. And if we can deliver it very carefully and to the appropriate doses, we can achieve very good results. And so lesions, I'll be discussing in detail what are the indications, what kind of lesions. So any lesion which is beyond 3 centimeter, even if it is less than 3 centimeter, which is not undergoing RFA, all lesions, which are not multicentric, more than 3 or 5 lesions, they can all be radiated. But the sparing the normal liver is very essential, and what we call it in the surgical terms as functional liver reserve volume. And then also it's the proximity to the vascular and the biliary structures, and the presence or absence of portal vein thrombosis. So I'll be covering each point by point. And we know, like this in 1991 Imami's paper, that TD5/5 is 30 gray and TD50/5 is 40 gray. So radiation oncologists would not think of going beyond 30 gray to the mean dose liver volume. And 1/3 of the liver volume had to be spared. But all these data, with this new data and hypofractionation and SBRT, this has been now challenged, and it is like there's a new concept which has come up. And RILD, I'm not going to cover in detail, but yes, there is a significant risk of RILD when we radiate these liver tumors. and especially on the background of hepatic cirrhosis, because majority of the HCCs, they develop on the background of liver cirrhosis. The rest of the liver is already damaged. So so then it is plays our doses to the rest of the liver volume is very crucial. And they are all, most of them are hepatitis B virus carriers, or maybe active disease. Then portal vein, many of them have portal vein thrombosis. So these are all risk factors which lead to increased RALD. And on top of that, when we have to radiate, we have to keep all these factors in mind. Now, radiotherapy role is in the primary liver malignancies, because if they are not going to be operated, they are termed as palliative. But now is again, we are giving higher doses even for this palliation to achieve more local control and progression-free survival. And of course, liver metastasis also is where we give radiation to these tumors. And target volume used to be, traditionally it used to be either whole liver or moving strip techniques. And it has all, we have gone away with those techniques, old techniques. And there it is a major paradigm shift, where even 3D CRT, we don't practice anymore. And we have gone to IMRT, and most of the liver lesions are amenable to SBRT with these modern techniques. And in 1992, there was an original paper from TMH, where they had shown that if they give whole liver radiotherapy of 30 gray over 20 fractions with the sequential MTX and 5FU, the palliation was achieved in 71%. So even in those days, say around 40 years back, we knew that radiotherapy is effective in these cancers. But of course, there were no modern radiotherapy techniques. So that's why the toxicity used to be higher. But even in this paper, 1992, median survival was 11 months when you gave radiotherapy to these palliative kind of cases. And conformal radiotherapy came in 90s, and there were small series published with small number of patients, and where they showed that even with the radiotherapy, the objective response rate was pretty high, and 1 year survival was at least 45 to 60%. So these were all 3D CRT techniques to the large tumor volumes and to the doses of 55 to 60 gray. And this used to be the old 3D CRT techniques, where we could not go beyond 50 gray in most of the cases. And there was another paper that, yes, where we radiate these lesions, there is typical, you can see the CT scan findings, where you see the blush after 1 month in the second image. Then the third image, post RT 3 months, this tumor is disappearing, and post RT 1 year. So it takes longer time for HCC to actually show complete response on the CCT scans. So we have to keep that in mind. The first CCT may show, in fact, enhancement or increase and pseudo progression. But when we follow up these patients subsequently, you see the response. And so in 2002, Park et al. From Korea, they published a paper that, yes, there is a dose-response relationship. So when you go beyond 50 gray, the tumor response is much more, and like 53.8% for tumors, 5 to 10%, and they had this response. So in this this slide, it's shown that if the dose was more than 50 gray, the response was 77%. And look at the toxicity on the other hand, on the other side, the toxicity was minimal. So if well given radiation, even the conventional doses, if you are able to achieve good coverage, you are able to achieve, you get a partial response in 77% of the patients. And this was the 3D CRT technique. And again, then Dr. Dawson et al., she is like a pioneer in liver SBRT. So first, in her first paper, it was with the conventional fractionation. Again, she showed that there was a dose-response relationship with RT doses of more than 70 gray and median RT dose of 58.5 gray. And here she compared that when the doses were between 70 to 90 gray, the local control and survival was much superior than to the lower doses. So this was in 2010. And so then she herself, actually, she was a pioneer and she moved on to giving SBRT or SABR or stereotactic radiotherapy. All these are this thing. And it is basically a technique. It's a philosophy of delivering very high doses that result in high tumor kill and achieving high local control. And with the technique and precision involved, ensures the sparing of the normal organs, which is the basic principle of delivering radiotherapy. And it can be delivered with linear accelerators, arc therapy, robotics, cyberknife, and technique doesn't matter. But very important is what kind of doses you can achieve with to what volumes and to what doses OARs are receiving. And I'm not going into very much detail of this SBRT because again, it's another subject of its own. So I'm just giving, but utilization of SABR is increasing, but still in GI cancers, upper GI cancers, it is less than 10%. But like in future, we expect there will be more and more utilization of SBRT for these liver tumors. And especially challenges are expertise, and there's a lot of training involved and QA and credentialing and better case selection. But of course, for you youngsters, there's huge opportunity in treating these cases and to achieve local control rates which have never been seen before. And there is opportunity also of integrating with now we have monoclonal antibody therapies, and we also have sorafenib, so there are many trials are happening, and there's a huge opportunity to treat this cancer. And so you must, all of you must be familiar with this chart of BCLC grading. So basically this chart is saying that if it's stage 0 or stage A to C and stage D. So stage 0 is basically all resectable cases. Stage BCLCB is intermediate stage where usually TACE is given, which is considered the standard of care, followed by surgery if they become resectable. And stage D is those large tumors and where it is only palliative treatment is advised. So, but I would say that radiotherapy can be given in all 3 stages. For if it is even resectable, but if it is medically inoperable or RFA can't be done for some reason, or you don't have RFA in your center, then definitely SBRT is a very good, reasonable option. And also in these resectable cases where they have been selected for liver transplant, then RT and there's no cadaver available or there's no live donor available. So meanwhile, to buy the time as a bridge to transplant, this SBRT is a very good option in these operable cases or who are going for liver transplant. Now coming to the second group of tumors where they are large and they are being evaluated for TACE. Again, so we are actually conducting a head-on comparison with TACE in IEA trial with SBRT. And there's another Dr. Supriya Chopra is the PI for another trial where she's comparing TACE followed by SBRT in the trial arm. So again, there's a huge role of SBRT in this intermediate stage of patients. And when there is portal invasion also, then we can give SBRT with a higher dose to the where there's a thrombus, PVT thrombus, and sometimes it can open up. And and we can get good results. And in this last group of patients, it can be only symptomatic, but again, it is a very good symptomatic relief, and there's a good palliation can be achieved for these last group of patients. So there is role of RT in all groups of HCC, you must remember. And this is one of our patients who had received who was unresectable HCC and received SBRT, and he had refused stays, and we see that gradually the scans, it is over 6 months it has responded, and he continues to be disease free at 3 years, and we have many more examples, and we have published the paper which I'll be showing you in the later slides. Now, how do we decide the doses? What kind of doses when we have to give SBRT? And this is a little bit tricky and a little confusing formula called V efficient dose, where Dr. Laura Dawson in her paper, there's a detailed paper, and how do we calculate, and there's a formula to it. But you concentrate on the right side of this chart, and you see that highest doses we give is 54 grain 6 fractions, where we can achieve the doses to the rest of the liver volume and the OARs. And then this is gradually, if the tumor is increased, more in size, or FLR is less, then you can continuously reduce the doses. And last dose achievable is 30 grain to 6 fractions. This is how we practice in daily routine at TMH also. Then now coming for the patients who present with portal vein thrombosis. So there is option, you can give a SIB. So you can give a high dose to the PVT area, and say 40 grain 6 fractions, and if it's a huge tumor, large tumor, like say 14, 15 centimeter, then the rest of the volume 24 gray and 6/6 fraction is achievable. And then this patient, there are 40 to 50% chance that this PVT will open up, and he may become resectable. So there are good chances, and we should take them up, because otherwise there's no option for these. Days cannot be done because there's a thrombus. And the only option is tablet sorafenib, and median survival with sorafenib is like 3 to 6 months. So radiotherapy can actually give them, can convert them into, few of them can be converted into curable, and they can undergo resection also. So this was a paper published. So so these were the studies, earlier studies of SBRT, which were published, and most of them have used, 3 fractions, 45 or 48 grain 3 fractions. And look at the local control, such good local control, 77 to 96% 2-year local control, and median overall survival is also, like it's relatively very good, considering this HCC is, they present with such locally advanced tumors. But this kind of local control is
not joked up.
Can you mute this person, Dodul?
Yes, ma'am, I am muting them. Many people are actually joining and they're unmuting themselves.
Yeah.
Please continue, ma'am.
Yeah. Now coming SBRT as a bridge to transplant, there are more papers now. First paper, this was published in Reg Journal in 2011. And the median overall survival, 2-year overall survival who underwent transplant was much high. So transplanted patients have a very good good survival, but many of the time, because as I said before, cadaver is not available, cadaveric liver is not available, the relatives are not matching, so there's time to buy this. So you can buy time by giving SBRT in this meanwhile, because, and also if there is progression, because there will be 1/3 of the patients will progress, like 20 to 30% of the patients, and they can be spared of unnecessary liver transplant because it's such an expensive procedure. So if it's an aggressive disease, so you can study in this 3 to 6 months while patient is waiting with SBRT for a transplant, if they develop more bone mets or other mets, so they can be spared of this unnecessary surgery. Now coming to the outcome following the TACE alone. So like now TACE has become a standard of care, and in most of the guidelines, TACE is the standard of care. Why? Because TACE was compared with observation alone. So the TACE was never compared with SBRT or any kind of radiotherapy. And we see that TACE, if you do TACE alone, there's 38% 2-year survival. And only in Barcelona group of patients, the survival was 63% with TACE alone. And when we compare, there is no direct comparison of SBRT with TACE, but we look at the survivals published with the SBRT alone. So this actually appears to be a little superior overall survival with SBRT compared to TACE. But since it has never been compared in a randomized trial, there are randomized trials which are on the way. And I'll be just showing a few slides of it. And it is very important, if in your center there is no interventional radiologist, or they are willing to give even after TACE there is no response, of this partial response, all these candidates can be given SBRT at your respective centers, and it will give good outcomes in these patients. So now the indications is, current indications are medically inoperable or high risk for anesthesia when they are BCLC-A. These are all resectable tumors. Or BCLC-A when they are waiting for transplant. Then BCLC-B, where TACE is either not feasible or it is not available, or there's partial response after TACE. So then all these cases can be offered SBRT. Then when they have main portal vein thrombosis, so then these patients again can be offered SBRT. And if there's local recurrence after TACE and still it is not resectable, they again can be offered SBRT. So now in the NCCN guideline also, it has been included in the BCLC-A, radiation, external beam radiation therapy is one of the options. BCLC-B, again, radiation loco-regional therapy. SBRT is one of the options now. And also in the Korean study group, again, SBRT or radiation therapy is one of the options for BCLC-B. And SBRT is given also as a part of multimodality treatment for unresectable hepatocellular carcinoma. Since there was never a randomized trial, or there was no proper comparison, so even the meta-analysis of TACE or TACE or versus TACE plus RT is equivocal. So, so there is definitely a need of proper randomized trial, high quality randomized trial, which will give us some indication either SBRT is superior to TACE or equivalent to TACE, and which tumors it is very effective. So this is actually, it's not highlighted. Dr. Supriya Chopra is the PI for this trial, which is underway, where we are comparing depth TACE in one arm, or even TACE, plain TACE is allowed, and depth TACE followed by SBRT. And this is underway. So now when it is BCLC-B or C, if they are not undergoing, if they are advanced stage, this SHARP trial showed that if sorafenib alone or sorafenib alone compared to placebo, if you don't do anything, then sorafenib gives a distinct survival advantage over either the placebo or just observation alone. This was a SHARP trial, and sorafenib, with this kind of treatment, you can achieve a median overall survival of 6 to 10 months or 11 months. And at present, RTOG 1112 is evaluating sorafenib alone versus sorafenib plus SBRT. So these are all patients with primarily having large SCCs with portal vein thrombosis or limited metastasis either to the portal nodes or to the lung, which can be encompassed with the SBRT volume. So this study is underway. Dr. Laura Dawson from PMH, she's the PI, and we have been credentialed for this study, and soon, I think in a month or two, we'll be starting this study at our center at TMH. So importance of child score, you must remember that yes, if it is higher the child score, the worse is the survival. And so RT can be incorporated in this child's A and child B, but child C is essentially palliative. And at TMH, when we started SBRT, I think in 2011, so we used to be referred only those big tumors. And so at our centers, surgeons are quite aggressive, and they operate even the large tumors which are outside the BCLC criteria. So so median tumor size of our surgeons operating is 9 centimeter. And sometimes when the tumor is much bigger, they give pre-op TACE. And if the tumor shrinks, then they undergo surgery. So this is like quite this aggressive approach. And for we radiation oncologists in the beginning, only these kind of big, humongous, hanging tumors are left to treat. But still, we in our SBRT liver program, we gave the SBRT to these tumors also, albeit lower doses. And we got some very good responses. So look at the pre-TACE and then post-SBRT, look at these comparisons. And there was a good shrinkage. And we realized that these are quite radiosensitive tumors. And even like these large, big 15 to 20 centimeter tumors can be treated with SBRT. And we can achieve good local control. And these were the doses, typical doses we were giving to the GTV 54 grade 6, like similar to PMH doses. And this study was published in 2019 by Dr. Supriya, and I was also one of the co-authors. And so the results of 53 lesions or 30 patients we published. And so in these big tumors also, so this was the kind of, the median T size was 9.3 centimeter. Dose prescription was typically 42 gray in 6 fractions. And the survival, we achieved, so most of the patients were hepatocellular cancers. And these are the outcomes as per the Barcelona stage. So if they were Barcelona B, they were 18 months was the median overall survival. And if they were C, it was 8 months, which is also quite decent for these big tumors with BCLC-C. And again, the child's criteria, if they were child A5, it was much better survival than child B7. So you see that the initial staging does impact the outcomes in these tumors. And again, the overall survival was median 17 months versus 10 months, though it was not, p-value is not significant where but of course the GTV, if it was small, means smaller tumor, less than 350 cc, had much better outcomes. There was distinct overall survival advantage of 24 months versus 8 months when the tumor was small, lesser than 350 cc versus more than 350 cc. And again, these are the charts, and the kind of toxicities were acceptable in our present series compared to the international series. And we have currently liver SBRT program running, and these are the outcomes which I have discussed. This is the kind of MDT that we have in our hospital. This is Dr. Laura Dawson, who's a pioneer of SBRT in liver, and SCC, and she's dedicated, I must say, her whole life for this SBRT in liver tumors. This is Dr. Morten Hoer from Aarhus, Denmark, who's also a lead in SBRT liver program. And these are the courses which we have been conducting. And it is very encouraging, the phase 2 data, and now with this low toxicity and with this kind of responses. And these are the 3 randomized trials. So one is IEA trial, where we are having head-on comparison of BCLC-B tumors. We are not taking with portal vein thrombosis in these tumors, and we are comparing SBRT versus TACE. And whereas in the RTOG study, we'll be comparing sorafenib versus SBRT on portal vein thrombosis patients. And then the third trial is we are comparing TACE followed by SBRT versus TACE. So these 3 key trials will definitely, in next 5 years, they will guide us, and it will give us very clear picture of what is the role of SBRT in these HCCs. So should I take up questions now, or I go ahead with the radiotherapy in liver metastasis, SBRT in liver metastasis? Dodal?
Ma'am, whatever you are comfortable with.
Yeah.
So last time we did it like after the topic, you took the questions.
Yeah. So I can do it now if there are some burning questions now, or
Okay,
I can
ma'am.
later.
So yeah, there is already a question. Is there a role of concurrent chemoradiation?
So no, there is an HCC, we don't give concurrent chemotherapy. In fact, sorafenib, if the patient is on sorafenib, before starting SBRT, they have to stop sorafenib at least 2 weeks prior to starting SBRT, because then the toxicity and RILD is much higher. So we don't give anything concurrent with radiotherapy.
And ma'am, after finishing SBRT, what is the right time to begin the systemic treatment again?
So at least 2 to 3 weeks, you can do the liver function tests, and if they are okay, they can start, or even after 4 weeks is good, good enough, because response of SBRT, it can be seen actually in after 3 months only of completing SBRT. So at least, I mean, some gap has to be given with sorafenib. There's no other chemotherapy, and yeah.
Okay, ma'am. The second question is there any data of radio frequency ablation versus SBRT?
No. So radio frequency ablation, the limit is maximum 3.5 centimeters, sometimes even 4 centimeters, and which are not operable, or which are in such a location where it will involve whole hepatectomy. So these are the indications for RFA, and there is no trial, and results of RFA for these small tumors are pretty good. It is similar to resection. So there is no trial, and it may be, so like if we prove this role of SBRT in these larger tumor, maybe in future there would be a trial, but it maybe not be considered very ethical also, because since the outcomes are so good with RFA, and it's as good as surgery. So I don't think it will be compared in the near future, but yes, maybe after many years, yes.
Thank you, ma'am. Dr. Richa has a question. Is there a role of indocyanine for radiotherapy doses in liver?
So we do how we calculate. Yes, we do a FLR, and the radiologists, they calculate the FLR, the functional liver volume. It is very important, yes, and then especially in the cirrhotic patients. So depending on that FLR, we calculate doses and we prescribe doses. Otherwise, patients can land up with liver failure. And even with these kind of doses, I must say, like around 25 to 30% of the patients, they have liver failure within 2 to 3 weeks. But we should not be alarmed with this liver failure, because it is reversible. And with good medical management, most of these liver failures are reversible. So it is a point to be noted that we should not be scared or alarmed with liver failures following SBRT.
Right, ma'am. Dr. Nikunj Patil has a question. Post SBRT, when should we do functional scans?
So functional scans are typically done at 3 months post SBRT, not before that, because if you do at 6 months, we have also done in few cases, and it might show a pseudo progression. So the capsule typically appears thickened and enhanced, and even in the PET scan, the uptake SUV values are more than the baseline. So we call it a pseudo progression. So we have to be aware of this phenomenon, and only after 3 months you can do an imaging.
Dr. Chiranji has asked a question. Is cirrhosis a contraindication for radiation?
No, definitely not. This, in fact, you will get these patients who have, most of the patients will have some baseline cirrhosis, because HCC develops in the background of cirrhosis. So it is not a contraindication. Functional liver volume is the most important factor.
And the next question is any data on role of radioembolization with yttrium-90?
So now so there was a randomized trial comparing yttrium-90 with sorafenib, and there was no benefit in overall survival. And yttrium-90 is such an expensive treatment of many lakhs. So it has no benefit. So in fact, it has gone down in a big way. There could be very select cases where they would give and hope for downsizing or downstaging, but radioembolization, the role has gone down drastically. You know, it used to be given for where we have portal vein thrombosis and where TACE cannot be done. But in the randomized trial, it has not shown any advantage. So it's maybe a very select group of cases, sometimes they may do it, but otherwise no.
Ma'am, there was a trial of this SIRT in metastatic colorectal.
I've not covered liver metastasis.
Yes, ma'am. Yes. Dr. Deepti has a question, ma'am. I think it's a very interesting question. Yeah. At what viral load of hepatitis B and hepatitis C in active hepatitis patients we can take patient for SBRT?
So actually, that I actually, frankly speaking, I don't know the cutoff value, but yes, we start them and there's antiviral therapy, and they are like typically 2 to 3 months, and then I don't remember the cutoff, but then yes, we first start them on antiviral therapy, and when they're stabilized, then we start with SBRT for these cases.
Right.
Yeah.
Okay, ma'am. Dr. Sriram has a question of how long we have to wait for considering a resection after SBRT.
So 3 months you evaluate, and yes, if it is resectable, so you can immediately operate after 3 months, or on an average, we see what we wait here is around 6 months. And surgeons are actually reluctant in operating after SBRT, because as it is, there's a background of cirrhosis and SBRT, but yes, very, very few cases they do it. And in that IEA trial also, we have allowed them. So if there is a response, they can go ahead with partial liver resection. But yes, it's a very good option for liver transplants, which we have to wait at least 6 months. I mean, typically they wait 6 months, yeah.
The next question is from Dr. Roshni. She has asked, which cases of portal vein thrombosis are feasible for SBRT, depending on degree of portal vein thrombosis or portal vein involvement?
So no, it only depends how much you can cover in your volume and OARs, you know, like sometimes near porta, like duodenum can come down, or so if the OAR structures are away, typically 1 centimeter away, you can radiate this thrombus to higher doses, 54 gray, 6 fractions or something like that. And the rest of the tumor can receive a lesser dose. So there are chances of at least 30 to 40% chances of opening up of this portal vein thrombus.
I wanted to share one information, ma'am. When I was doing my fellowship in New Jersey, Dr. Salma Jabbar, who is part of this RTOG GI group, she used to do a lot of liver SBRT, and I have seen not many of the patients having lymph nodes in the vicinity of the primary tumor. She used to consider that within the gross tumor, including the portal vein thrombosis part, everything within the gross volume.
Yes, yes, exactly. You can do. In fact, if it is like few cases, you see even the metastasis, even the lung metastasis, which is in the vicinity, we include that.
Yes, ma'am.
Yeah, there is no this thing that, yeah, you can, limited metastatic disease can be included.
Dr. Deepti has another question, ma'am. If the portal vein thrombosis is extended till confluence of SMV, then what should be the approach?
But SMV, it will be, as long as you can achieve, your target doses to the OARs, especially duodenum. So I think in this case, duodenum, achieving doses to duodenum may be a challenge in this. So I have not seen such extensive thrombus going up to the SMV. But yes, up to main portal vein, and we have even in the IVC, we treated one case where where there was a thrombus in the in the IVC, and it was but near to the GTV. So like we could include everything in the GTV, and we could radiate. So it all depends, how far is your duodenum or stomach or OARs away or bowels away from this. Is it okay? Then I should go ahead with the liver metastasis. Hello?
Hello?
Yeah?
Yeah, ma'am, can you hear me?
Yeah.
Uh, there are 7-8 more questions, ma'am. Should we take it right now or at the end?
No, we'll take it later.
Okay, ma'am. Okay, okay.
So about radiotherapy in liver metastasis, again, there's a lot of data coming up for this, and where we see primary metastasis from colorectal or from breast or melanoma, lung, etc. And so hepatic metastasis, like there was typically no role, and there was no benefit with EBRT alone. And we saw that with concurrent chemotherapy, it was given the SBRT for the liver metastasis. But there have been few studies. There are no major randomized trials, and so if they are unresectable, so typically when the liver metastasis, if it is colorectal liver metastasis or oligometastasis, they are resectable. But when they are unresectable, medically unresectable, or they are much more bilobar disease. So these are the typically cases where we can give SBRT to this liver metastasis, and it is evidence is evolving. And for the colorectal metastasis, right now I'll be covering in the next slides. The 5-year overall survival ranges from 30 to 40%, and so non-surgical ablative techniques can be used. And this is just a picture of showing SBRT for the liver mets. And there have been many small retrospective phase 2 cohorts which are reported in literature, but local control rates are pretty good with these small cohorts, up to the tune of 80%. And SBRT, from the colorectal metastasis, the local control rates are lesser compared to when there are liver metastasis from the other sides. Because you should always remember, the liver metastasis from the colorectal cancers is more radio resistant than the liver metastasis from the other side. And there are newer techniques, protons and all will be available in the future. And this was another paper which was published that the median overall survival was 2.4 months after SBRT, and even when we compare colorectal liver metastasis with the other metastases, the median overall survival is like second in the line. The best is with the breast cancers. So when you have liver metastasis of the breast cancers, yes, you should not shy away from giving SBRT to these tumors. But colorectal metastasis is second in number. Excuse me, lecture shall run. Yeah. So again, this is another slide where the size of the largest metastasis was less than 30 mm, and then the overall survival after SBRT for metastatic colorectal carcinoma is if the overall the prognostic factors were 3.3 years, it ranged from basically 0.1, less than 1 year, to 3.3 years. And even the local control was good, and especially if the BED doses were more than 100 gray. So most of the literature and most of the papers, they recommend a higher dose, typically 45 to 50 gray over 3 fractions, and when there is colorectal liver metastasis. And so sarcoma and colorectal metastasis is definitely more radio resistant than the other tumors, and it has average radio sensitivity is lesser compared even to the sarcomas. And the best is by breast cancers, breast cancer liver metastasis. And additional factors, like there is definitely a dose response relationship. So if the tumor volume is lesser, you should opt for higher doses, and typically in 3 to 5 fractions. You can go up to 60 gray, as Ju et al. Had given 60 gray in 3 to 5 fractions. So it's the higher the dose, the better the local control, and definitely it can. It is achievable because these are smaller tumors compared to HCC, and if the volume is more, then the control is less. It is this is typically. So if you find the patients with young age, good performance status, good slowly progressing cancer, especially breast cancers and all, SBRT is emerging as a very good option for these tumors. And you can combine them with systemic anti-neoplastic therapies because these are all metastatic cases. And if you give chemotherapy along with it, so definitely there's advantage in survival along with chemotherapy and SBRT. And even in the ESMO consensus guideline of oligometastasis, SBRT is enlisted as one of the options for treating these liver metastases. And what about RFA or SBRT? So again, there is no randomized comparison between RFA or SBRT for colorectal liver metastasis, but we see that in this patient, they had a comparative analysis, and local progression-free survival was much superior in the radiosurgery arm. They were all treated by CyberKnife, and it was better than RFA, but overall survival, there was no difference. So definitely radiosurgery and SBRT may stand a chance compared to RFA, but there are currently no randomized trials happening also, which I know of. And so at oligometastasis, liver metastasis, local control is like it can be achieved 80 to 95% in many of the diseases. And so it is very evident that SBRT, along with other treatments like surgery, microablation, RFA, chemotherapy, SBRT has become a part of the multidisciplinary management of liver metastasis. And we at TMH have had a very less chance of radiating patients with SBRT because we never had any trial, and we have a few cases, but lot of disturbance, yeah. But since we have a restriction of have number of patients on the machines, so we could never start off any study for the oligometastasis of SBRT of liver, but in future that could be a possibility. And so in conclusion, there is a long-term survival and better local control can be achieved in metastatic colorectal cancer of liver metastasis, and morbidities and are very few, and there is a requirement for phase 3 trials to compare with other modalities for these cases, and our experience is definitely less for compared to the HCC. Now coming to the cholangiocarcinoma, I'll quickly cover because there's not much, again, there are not much trials. And this we had published in 2017, this paper where we had given, for these Klatskin tumors, we would give brachytherapies, then followed by SBRT. Not SBRT, the conventional chemoradiation, and other group we compared where we just gave external beam RT with concurrent chemotherapy. And this brachytherapy, which we do now in much lesser patients, that time we used to give by, and during the time of PTBD, we would typically insert these catheters, and this at the junction, this is a Y-shaped, we would prescribe our doses because these are at junctional tumors. They're called Klatskin tumors. And this would, if they were not having metastasis on subsequent scan, we would plan them with EBRT of 45 gray and to 25 fractions. And this was the targets. And our median overall survival, where we gave, there was not much difference between where we gave brachytherapy followed by CTRT or just concurrent high dose CTRT. Our median overall survival was 16.5 and 16 months. And but the patients who responded to external beam RT, they have a better overall survival compared to the poor and partial responders. And our study was again comparable to what is published in literature. The toxicity was cholangitis because that's a part of the disease. So it is not because of the radiotherapy, it is because of repeated stenting, and also so they have lots of patients have, almost half of them have cholangitis. But late radiation toxicity was much less in our cohort of patients. And so there were encouraging results. And right now we are doing this trial where we are comparing standard systemic chemotherapy. So these are all unresectable cholangiocarcinoma type 3 and type 4. Most majority of them are type 4. And the standard arm is 8 cycles of Gemcis. And the experimental arm is chemotherapy and high dose chemoradiation, concurrent chemoradiation. And it is still undergoing, the accrual is slow, but yes, in next 2 to 3 years, we should get the result. And in other Mayo group, they do NECTRT followed by liver transplantation for these cases. And again, the data is sparse, but yes, it is there. What I would like to stress on about the management of cholangiocarcinoma, so it is relatively radio-resistant. HCC is quite a radio-sensitive tumor, but cholangiocarcinoma is inherently radio-resistant, and therefore there's a huge dose-response relationship. So if you can achieve, so in this study, they gave 30 gray over 3 fractions, and the local control is almost into 85–90% of the patients. But overall survival, and ultimately they have distant metastasis and they die of it. But this was the good paper. This is another paper where they again showed with from MD Anderson, it was a retrospective cohort, and they showed that yes, there was a dose response, significant dose response relationship. So where they could achieve, this was the kind of doses they gave. They actually drew GTV, and they drew the volume inside. So they gave a kind of SIB, simultaneous integrated boost, to the dose of 100 gray inside the tumor, and outside it was 45 gray PTV. And since most of the cholangios, like you can see, the stomach is very much in the vicinity, so they gave expansion, the PRV, to the stomach, and they deducted from there, and they could achieve these high kind of doses. And they showed that local control and survival was definitely look at the local control of BED of more than 80 gray versus less than 80 gray. And it was, the local control was superior, where the BED was more than 80 gray. In this first slide, you can see that. So it is in our daily clinical practice, even we at TMH, we practice these kind of doses, and especially for this intrahepatic cholangiocarcinomas. So where we can achieve the doses, we use the fractionation. Sometimes I use for intrahepatic cholangiocarcinoma 65 gray over 15 fractions. And this is also with concurrent chemotherapy. And this is this achieves gives us the BED of more than 85 gray. So so the local control is definitely superior when you go to these kind of doses. And there was another excellent paper by Dr. Brunner et al., where again the BED, where he gave SBRT for these cholangiocarcinomas, and he showed that a BED of more than 76 gray had significantly better local control as well as survival. So as radiation oncologists, it is our desire, and with these new techniques, to give higher and higher safe doses to these kind of cholangiocarcinomas, because they are relatively radioresistant, and it is achievable, and wherever it can be achieved, it should be practiced, these kind of doses. I think I've finished with my talk, and I can take the questions now.
Thank you, ma'am. I think we can start the remaining questions from that SBRT for liver.
Yeah.
Okay, ma'am. The remaining questions, the first one was whether you recommend SBRT in a 10 centimeter or larger tumor.
Yes, so I think the largest volume we would have given is around maybe 20 centimeter.
Yeah,
so,
you told that during the talk.
Yeah. And then in the IEA trial, where we are comparing head-on with the TASE, our maximum size is 12 centimeter for that trial. But size is actually not the limit. So the limit is the functional liver volume, and that I'm stressing. You may have a larger liver left, but if it has to be functional liver, so size is not, like you can give up to 15, 16 centimeter. And so even if you can achieve 25 gray over 5 fractions or 30 gray over 6 fractions, that's a very good dose for a HCC.
Yes.
So
how frequently do you administer the treatment in a larger tumor?
What?
What are the fractionation schedule that time? You treat alternate day, twice a week?
SBRT is alternate day and 5 to 6 fractions. So usually if they're larger, we try to give 6 fractions, not more than that.
Okay. And any cutoff serum bilirubin level prior to starting SBRT?
No, SBRT has no this thing. If it is liver enzymes and all, you should look into. Patient should not be already in failure. There should not be ascites. It should be fitting into child's B7 or borderline B8. Also, you can take some of them. So all these are other criterias.
Ma'am, do you recommend SBRT in a patient having esophageal varices with active bleeding after doing banding or sclerotherapy?
No, we wait. After the active bleeding, we wait, and usually they are controlled. So medically, if they are controlled and they are not having active bleeding, then we give SBRT.
Okay, ma'am. And there is another question. Any minimum functional normal lung volume required to consider a patient for SBRT?
No,
I
because
think that's.
lung volume is never a problem. Lung volume, why
I
it
think it
should?
should be a liver volume.
Yeah.
So I think the question should be the absolute, the functional
Liver
liver
volume.
volume. I think this is put in a wrong way.
Yes. At least
Uh,
700 cc of the functional liver volume should be spared. So then you can achieve, if you can achieve these kind of doses, otherwise you reduce the doses.
Ma'am, practically speaking, what should be your recommendation in a department to begin SBRT liver program? What should be the basic requirements?
So basic requirement is, of course, you have to have a 4D CT, and where you can practice breath hold techniques. That they are free breathing. Otherwise, it takes quite a longer time, and like that. So we give most all our tumor. There should be a good radiology department, interventional radiology department. They can place the, like, you have to have gold markers placement, and it means taste support, radioembolization support, all those good IR department, good surgical department, good MEG GI department to manage all the liver failures. So all these things are there. Of course, the technology has to be there, 4D CT and breath hold and IGRT and these new modern machines where you can deliver. So, and we use usually now triple F. We treat all our patients on true beam with triple F technique and with high dose, very high dose rate up to 16, 1800. I think 1800 we prefer to give.
Okay. Okay. There's another question. SBRT in Klatskin tumor, I think. Is there any role of SBRT in Klatskin tumor? I think that was asked before you took the class on Cholangio.
Just hold on, my phone is ringing. Yeah. Just, yeah. Yeah. What is the question?
Role of SBRT in Klatskin tumor.
So yeah, and then my last talk also I said that yes, it is achievable, and you can give, but then you have to regulate the doses to the duodenum. So that can become an issue because Klatskin is very near to the duodenum. So if it's and you have to have a proper breath hold technique. So if it is away from duodenum and it can be achieved, these doses, yes, there is no, means you can give SBRT. But many of the times we find that it's very difficult to give because length of the lesion is more and it is coming up to the mid CBD or your target volume. Then
Right.
like duodenum is very near and you end up with ulcers in the duodenum.
Right. There is a interesting question. Role of whole liver palliative radiation like in lung bath. Any role, ma'am?
No, there have been this thing. So palliation, like palliation also, there are few studies of liver, but we don't practice whole liver. That it could be toxic, very toxic, especially when these patients have like large tumors, and also whole liver is like, it's not practiced. I've not seen anybody practicing.
What dose constraints we use for stomach in SBRT liver?
So stomach and is for any SBRT, the dose constraints remain the same, like in pancreatic SBRT. So less than 1 cc should receive V33, and like V30 is I think 4 cc. And so there's a chart where OARs is concerned. So this is what we practice for liver and duodenum. Even V30.
Right.
V15, V30, it should be all regulated.
Thank you so much, ma'am. And I think there are no more questions.
You can, yeah, there are no more questions. It's good. Yeah.
Yes, ma'am. Just last question from my end, ma'am. If you are asked about a single important organ at risks to be saved during SBRT liver and during this cholangio, then what is that organ?
So it will depend on the location of tumor. See, if it's in segment 3 and 4, then there'll be stomach and esophagus can come, and this side, if it's above in the segment 8, and lung can come. So it will depend. And liver is such a huge organ, so it depends on which location the tumor is. But it should be from organ at risk, it should be away of minimum 5 mm to 1 centimeter, the organ at risk.
Right.
Between a tumor and the organ at risk.
Okay. Is there anyone who wants to ask any question to ma'am? Please, you can unmute yourself and you can ask directly and interact with ma'am. And if there is none, then we can end the session today.
Yes. If is anybody in the SBRT at their centers?
Ma'am, your voice was broken in between. Please say it again, ma'am.
Is anybody in the audience, they are doing SBRT at their center, SBRT of liver?
Yes, ma'am. I think many centers are doing SBRT liver, including our center also.
Okay. Okay. And how are the responses or any observations they can share there?
Yes, ma'am, it's difficult to predict that way because the data most of the time are not maintained that meticulously. So it's like a routine on a patient to patient basis treatment is done, but then to accumulate that data to analyze that, I think most of the time that is not done in most of the private centers.
Okay, and kind of what I said, these kind of 5 to 6 fractions, 54 gray or 48 gray, these kind of doses are being given?
Not that much high. Most of the time, I believe it's like within 45 to 48 gray in 6 to 8 fractions.
Okay. Okay, okay.
And I know personally, like at AIMS, SBRT liver is being done. At ILBS in Delhi, Institute of Liver and Biliary Sciences, they also do SBRT. And in Delhi, Max, Medanta. So almost all well-equipped private centers they are doing.
Yeah, I know.
Yes, ma'am.
Yeah.
And almost in all good centers who are having good machines for DCT, good dosimetry and physics department.
More for liver metastasis, whereas here we don't do because we have restriction of machine. But
yes.
Liver metastasis, many of the centers are doing, and which is a very good trend. Yeah.
So for cholangio, even I have also done, but it's this number is not that much great to analyze or to share actually.
Yeah, good.
Because we don't get that many number of patients.
Yeah, great.
Okay. Back to picture.
Okay. Anyone having any specific question? Please, you can ask. Unmute yourself. And if not, then ma'am, I from behalf of all of us, really thank you so much.
Welcome.
And we would like to have you again in future for next classes.
We can have rectal cancers.
Yes, ma'am.
Okay.
Okay, ma'am. Thank you so much, ma'am. Thank you so much. Good night, ma'am. Good night, everyone.
Second class.